Good morning, everyone. This is Professor Dunham, and I'm going to talk about Chapter 10. So please open your books to Chapter 10, and that chapter covers nursing care of women with complications after birth. So now you have the picture in your head. She's had her delivery, and depending upon her delivery, is that we can critically think now what's going to happen. Remember, you have on your nursing caps, so you're going to think like a nurse. Okay, so how I want to start out is, remember, I always say every week, and I hope that you're doing it, is the key terms. So we talk about atony, or I say it atony, and I say it that way because you can remember it better that way, is without tone, without tone. So if you've got your book, you could just put that in there, right in your book, without tone. The next one is called curettage. A curettage is what we do when our patient is bleeding after delivery. And you may know it as dilatation and curettage, but a curettage is just cleaning out the uterus, okay? Now the next step is endometritis. Just like it sounds, endo means inside, we're correct? And metriitis is inflammation of the uterine lining. Now that is an infection. So we want to go ahead and put a little star next to that, an infection. So when you're already thinking infection, we're thinking, oh my goodness, she is sick. So she's got a temperature, her pulse may be high. So start thinking, what am I going to do? Well, maybe her lochia is foul smelling. That's an indication of an infection. Okay, the next term is called a hematoma. A hematoma is a collection of blood. So if she had a tough delivery, if she had maybe a vacuum extractor or a forceps delivery type of delivery, then she would what? She could create her own hematoma or have a hematoma, and that is very painful. Okay, the next one I want to talk about is hypovolemic shock. And we're going to go into this step by step. When a person's in shock, what happens? Okay, and hypovolemic means that is what? Is low volume. Is low volume. And so low blood volume. Okay. And then involution. Involution, we've already discussed this, but let me repeat it. Involution is how the uterus, what? Descends after delivery. So right after delivery, her uterus should be at the level of the umbilicus. Now, every day, the uterus will descend 1 centimeter per day. Okay, so that's involution. And that's what we want. We want to have the uterus involute. It has to go back down. It took 9 months to get it the size it was, okay? And now it takes time. But the involution process is pretty good. If you're thinking 1 centimeter per day, about day 10, the uterus is already shrunken up to be what? Almost down in the pelvis. Okay. Now, the next one is mania. Okay, we'll discuss that. That's on page 257. And then we go to mastitis. Mastitis is inflammation of the breast. It's an infection. It's horrible. And there's a good picture in your book about what it looks like. Okay, and that's what we want to avoid. Remember, we talked about making sure that the baby latches on properly. Well, this is why we want to avoid. If we have that baby latching on to mommy's breast properly, the entire areola in his mouth, then we can avoid infections such as a mastitis. All right, and then mood. Well, we know about moods. Moods is how she feels. Remember, there's going to be severe hormonal changes after delivery. So then her mood can what? It can be erratic. All right, and then psychosis. Well, this is pretty advanced mental state in which they actually hear, voices and all different things. So it is something we have to be worried about, and that's called postpartum psychosis. All right, and that is on page 256. Okay, and then you have puerperal sepsis. And puerperal or puerperium is another word for postpartum sepsis. Our patient is very sick. And that's why everything you do to the patient in labor and delivery has to be, the sterile technique has to be followed because she is wide open to infection. All right. And then subinvolution is a term that you thought, well, involution is when the uterus decreases. Well, subinvolution is where there's actually a delay in that. All right. So that's your key terms. I just did them for you. All right, let's move on to what we're going to discuss in this chapter. So I want you to get your highlighter and highlight shock. Now, shock is defined as a condition in which what? Your cardiovascular system fails you. It fails to provide the essential oxygen and nutrients to the cells. So postpartum shock, there's three of them. There's three types. So one is cardiogenic, and that one is caused by a pulmonary embolism. They are more prone to those. And then anemia, hypertension, and then you have cardiac disorders. So cardiogenic is involving cardiac disorders, blood perfusion. All right, then you have hypovolemic shock, and hypovolemic shock is caused by hemorrhage, a postpartum hemorrhage. Now, postpartum hemorrhage is never good, and or you have some blood clotting disorders, such as DIC, and you can have those after delivery. And then you have septic shock, and it's caused by a postpartum infection. So remember that these are all danger signs, danger of shock in the obstetrical world. Is that the body compensation can mask the signs until the conscious becomes life-threatening. All right. So that's shock. Okay. Do we want to keep our patient away from that? Yes. All right. So then you got hemorrhage. Now, let's get your highlighter out, please, and let's go ahead and put down under hemorrhage. You want to highlight this. So postpartum hemorrhage, this is the definition that we all use, and is defined as blood loss greater than 500 mLs after a vaginal delivery, and then or 1,000 mLs after cesarean. Well, that's quite a bit of what? That's quite a bit of blood loss, okay? But thank goodness that she has enough blood volume during pregnancy, because remember, it's increased from 45 to 50%, that she can compensate for this kind of blood loss, like 300, 400 after delivery. But when you get to after vaginal delivery, if you get 500 or greater, you got a hemorrhage, and you got to act fast. Your patient can bleed out very, very quickly, and then you really have a problem. And the major risk of a hemorrhage is your hypovolemic shock. Hypovolemic shock. And what that does, that interrupts the blood flow to body cells. Okay. So on that same page, 247, you'll see hypovolemic shock. Again, going to repeat it. It occurs when the blood volume is what? Depleted or down. Okay. And it cannot fill what? Her circulatory system, right? Because circulation, got to have blood what? Diffusing. All right. Now while we're on hemorrhage, let me just give you a few definitions that you need to know. And that would be early. And that's within early hemorrhage is within 24 hours postpartum. And then late hemorrhage would be between 24 hours and 6 weeks. So yes, when your patient goes home, she can hemorrhage. And again, a major risk is hypovolemic shock. And again, I'm going to say it again, it's pretty important. It interrupts blood flow to body cells, okay? Your cells need blood. You know that inside blood vessels, you carry oxygen. And so without it, you would have a tough time, breathing after delivery. How about nutrient delivery? Sure, it all prevents, all this prevents. And then you have waste removal. Now, I want you to write this down. So get a piece of paper and pencil, because when you write something, you remember it better. Hemorrhage, the signs and symptoms. The first sign and symptom is tachycardia. Heart rate is going to go up. Why? Because the body senses what? That there's a loss. Okay, so she's bleeding out, and it could be like a gunshot or anything else, but the body loses its ability to provide oxygen to all the body cells. So therefore, the heart rate goes up. If the heart rate goes up and she's working really hard, then the body has the blood pressure does drop. So heart rate goes up, blood pressure goes down. Okay, does that make sense? Now, if you're not circulating blood, what are you going to look like? You're going to look pale. You're going to be cold, like clammy skin. Not a good sign. Okay. And then all this, the brain will get involved. The brain needs blood. The brain needs oxygen. And what happens is that the mental status starts to change. So she could get disoriented. And then on top of it, the kidneys are going, hey, I need that blood volume. I need that blood. And so if you're not circulating all this, the necessary blood, then the kidneys start to fail. So you'll have a decrease in urinary output. So make your like a little stick figure, okay? And put up there hemorrhage. And then draw in a little heart. And then take your little heart and make your line and put increased heart rate. And another term for increased heart rate is tachycardia. Okay, so you got the heart. Then the blood pressure. So put a little blood pressure cuff on the stick arm and make it like a little square and put your line and put down decrease heart blood pressure. Okay, and then you put for skin, make it real pale and clammy and just put cold. So just think, you go outside and it's real cold. What happens? Your body starts to get really get uptight, right? Okay, and of course it's pale. There's no more color. Don't us ladies like to put blush on us because we're looking kind of pale? All right, and then put on top of the little guy's head the brain. Okay, his head. So put a little circle up there, and then draw your stick line and say changes in mental status. Okay, now the last thing, come down to where the kidneys are and this little guy, draw your kidneys, okay, like little lima beans, and then put down decrease urinary output. When you're drawing this up, you're going to remember it better. So take my word, please create your own stick guide. Okay, all right, so let's go on. Remember, hypovolemic shock, if your nurse doesn't act quickly, she doesn't recognize these signs, your patient can die. So is that important to know? Yes. Yeah. You have to have blood flowing through the body. Okay. Now, we went over the body's response to hypovolemic shock. And so I want you to basically review that again, but we just went over that. All right. So what are you going to do as a nurse? Got your thinking cap on, right? You got your nurse's cap because we're going to critically think. Okay, so what do I got to do for this person that's hemorrhaging, who's got all this blood coming out? Get this picture, okay? And you want to stop the blood loss as quickly as possible. So what you can do is on a postpartum patient, I would definitely, if she's hemorrhaging, I'm going to check that uterus. I'm going to make sure that my fundus is firm. And if it's not firm, then I'm going to massage it. And then she has an IV. She might need another IV because we might have to give her more circulating volume. Sometimes we give volume expanders, cryoprecipitate, platelets, blood. And so we want to replace these things quickly. And of course, I have oxygen on her. Yeah, oxygen will help. I have a pulse oximeter, I have a blood pressure cuff on her. You get the picture? Okay. And then I'm going to probably put in a Foley because I'm giving all these different fluids, and I got to make sure that what goes in does come out. And what else? Remember our little lima beans that you drew? We said decrease urinary output. I've got to make sure that what? She's got kidney function. All right. All right. So that's the importance of hemorrhage. Now on under announcements, I did put up simulation of a postpartum hemorrhage. If you haven't looked at it, please look at it. It is very informative, and it shows you how a team works together in order to take care of a patient who's in a postpartum hemorrhage. We consider those postpartum hemorrhages as an obstetrical emergency. Those are our code blues. So yes, you must act quickly, and we call it PPH, postpartum hemorrhage code. So you'll hear her say PPH code, and that's exactly what goes on. And take note to the IV, take note to the fundal massage, take note to everything that's going on in there, the medication, how one is a recorder, and it's very informative, and it'll show you exactly how quickly they intervene. And what was the problem in this one? It was placenta fragments. Okay. All right. So I'm going to move on to the next one. Is called anemia. And anemia, what? What is it? It's just a loss of erythrocytes. What are erythrocytes? Red blood cells. Okay. So if I'm losing red blood cells, what's going to happen to my patient? She's going to get dizzy, lightheaded. Because why? Because my brain needs circulation. My brain needs blood. And if I'm not have enough blood, I can get dizzy or lightheaded. It makes sense. Every organ in your body needs blood. All right. And if she's anemic, and during pregnancy, she was given iron, then she is advised to keep taking that iron after delivery. And we're going to make sure we bring her back up to normal. All right. So as a nurse, I already said once before, what are you going to do? All right. Well, we're going to do frequent vital signs. Got to monitor our patient. Number 2, monitor oxygenation saturation levels. I got a pulse oximeter on the finger. Number 3, assessment of lochia. Be lochia rubra, and it should be without clots. And I'm also going to, while I'm looking at the lochia, I'm going to observe to see if there's any perineal hematomas. And then, of course, assessment of my fundus. And then we want to make sure that she's firm. Now, say she's firm, okay, and you still see blood coming out. That could be from a vaginal laceration. So that could be a difference. And then you have accurate measure of intake and output. Exactly. You don't want to overload your patient with too much fluids. So I want to make sure the kidneys are functioning. So I'm going to put a Foley in. And then I'm going to monitor for signs of anemia, lightheadedness, dizziness. And then, of course, I'm going to draw some blood to see what her levels are, and then provide emotional support to the woman. Is this scary? Yes, it is. Just like in that film I showed you, that lady was very scared. She just, she just had a baby, and it's supposed to be a very happy time. But, that's what my patient always told me when I had him in, after delivery. And they said, I think I'm peeing on myself. I don't feel well. My eyes got real big, and I looked down and I saw the blood. Okay. Then I checked her fundus real quick and saw if it was soft, I would do fundal massage. And seeing that she had copious amount of lochia, which is a large amount, I would ring for my team to come in because I cannot do this by myself. Okay. All right. So I'm going to repeat the early primary postpartum hemorrhage signs. It occurs within 24 hours of birth. Write that down. So early hemorrhage equals occurs within 24 hours of birth. Okay, the next one is my causes of this hemorrhage. So my causes are uterine atony, A-T-O-N-Y, or a uterus without tone. Yeah, remember, that's what we're talking about. And then lacerations or tears in the perineum or the reproductive tract. I'm looking for, the lacerations can occur and then they're not seen. Okay. And then, we put our legs down where everything's good, but she's still trickling this blood. Okay. And that's not right. So we want to go ahead and get the doctor in there, because a lot of times they have to go back in and they got to put a speculum to actually visualize to see where actually the laceration is. All right. And then, of course, the third one is hematomas in the reproductive tract, a collection of blood. And let me tell you, and I think I've already said once before, because I always remember my patient that had this large hematoma. She was in so much pain, she would tell me that pain, that hematoma, caused more pain than her labor. That's pretty bad. All right. So we're going to now define these three entities. So uterine atony, or ATONY, is collection of blood in the uterus. All right. So muscle fibers, afterwards, remember the uterus is made of 3 different muscle fibers. And so afterwards, they've been contracting a long time, and, they become what we call very tired or flaccid, and they don't want to compress anymore. So what happens, that placenta site bleeds. Okay. So just think, here's your uterus. Remember, inside there was the placenta. Remember the maternal side? Okay. So remember, at delivery, that breaks away. Okay. That actually breaks away from the endometrium to be delivered. All right. And it has its own stage, right? The third stage of labor. So what happens is that when that placenta comes off, there's a lot of blood vessels there. All right. Now, if that uterus does not clamp down, then those blood vessels are going to be what we call a free bleeder. They're going to bleed, and they're going to bleed large, because it's a highly vascularized area. Okay. So they're going to bleed. And all of a sudden you have all this bleeding that comes out. Okay. And so that's why we want to what? Massage the fundus. Okay. Because if you see my hands, it's like kneading bread. If you ever kneaded bread, it's like, getting in there and getting that uterus, and I am massaging you. So remember, one hand goes on top of the fundus, the other one goes on the bottom of the uterus, and I got my patient's uterus in my hand, basically, and I'm getting there, and I say, oh, I know it's there. Come on, uterus. And you can actually see it firm up, and now you can feel it, and now it's nice and firm. Okay, so that's the main thing. Also, if you've got a uterus that's distended, you might have a bladder that's full. And sometimes what happens is that the uterus should be midline at the level of the umbilicus after delivery. That's perfect. Now, if you notice that her uterus is above the umbilicus and deviate over to the right, then my bladder is full. So I got to empty a bladder. When you empty the bladder, the uterus comes back over and be in its place. And then you have a decrease in your bleeding. Okay. Now, we talked about, remember, during the labor, if she had a prolonged labor, and a prolonged labor also can cause her to have a uterus atony, because the uterus now is tired. It doesn't want to contract anymore. It's been working really hard for hours and hours. So that prolonged labor, we have to worry about those ladies that don't make the nice Friedman curve and are in labor a little bit too long. So if I have a patient that was in labor a very long time, I'd be watching her very carefully after delivery. And then, of course, we know placenta fragments does cause the uterus to not contract and to be without tone. So that's another one. And then, some drugs we use, the opiates that we use, everything, gets affected, and so does the uterus. And so that could cause the uterus to relax. So that's why. So what is it difficulty to feel soft, boggy uterus? Well, when you get in there, you know that should be here, a certain anatomical outline of the patient's body. So I know that uterus should be there. So I'm going to have to really go deep in order to find it and to get it nice and firm. All right. That is uterine atony or I-A-T-O-N-Y. I say it is that uterus without tone, which is atony. All right. We talked a little bit about lacerations already, but I'm going to repeat it. It does occur in the perineum, vagina, or cervix, and it could be around the urethra. It's just if she had a tough delivery, she had a big baby. Now can happen, and these areas again, they are very vascular, and these areas are like they're getting gorged. And blood is usually brighter red, brighter than the lochia. And this wasn't the difference. It continues in a continuous trickle. Okay, trickle of blood. Now, I've seen that on a question on a test where they asked what kind of blood. If it was a trickle of blood, what would it be? And that would be a laceration. All right. And then for lacerations, your uterus is usually behaving itself and is contracting. And then I would get my doctor back in there so he can take a look. And since I'm thinking, she has this laceration, she's going to have to probably get it sutured up. What am I doing? I'm critically thinking, what's going to be the next step? So what do? I do not give her fluids. I like by mouth. I keep her NPO. Okay. And so because I'm anticipating that she's going to go to surgery. So I don't want to give her anything by mouth because that would hold up her surgery, and she's bleeding from the laceration. That needs to get done very quickly. So I'm going to first call my provider and get him in there, and then he can make the decision as to suturing, and she's NPO, so anesthesia will be very happy with you. Okay, the next thing we'll repeat, I'm repeating myself a little bit, but that's okay, is a hematoma. Now, hematoma, again, is a collection of blood within tissue, correct? All right. Then it can cause by birth trauma, and usually it's on the vulva or inside the vagina. It's a tough delivery. Sometimes they use forceps, like I said before, or vacuum extractor. And those things can really hurt. And remember, things that occur during the delivery, she's going to live with afterwards. Okay. So we always keep it in mind too, as to when we're taking care of this patient. And then the hematoma is bulging. It kind of bluish or purple in color. It is, I love how your book puts it. It's unrelenting pain. And analgesia doesn't do much for her. Those analgesics like oxycodone, they don't do much. And they complain of a lot of pressure in the vulva, pelvis, or even in the rectum. And it's hard for them to go to the urination, to go to the bathroom, and it's hard to have a bowel movement. Okay. And so these hematomas can be so hurtful, really. Let me put it that way, hurtful. And they don't have an unusual amount of lochia, no, because the blood is collecting underneath the tissue, is all swollen and stuff. So they don't have a whole bunch of lochia. All right. Now, going to go to the other terminology that I talked about in the very beginning. It's called late postpartum hemorrhage. Late. Okay, so late is late, right? So it occurs after 24 hours up to 6 weeks after birth. And what's the causes? Well, we already discussed that. What? You tell me what that is. That is placenta fragments. Okay, and this type of late postpartum hemorrhage is the failure of the uterus to return to its pre-pregnancy state. So that falls under the category of subinvolution. You've heard that term before, subinvolution. So what are you going to do? Well, we're going to teach the patient how to report persistent bright red bleeding. Remember, on the last chapter, we talked about that. We talked about lochia and how it changes in a different color, from lochia rubra to serosa to alba. So this is important with discharge teaching, is that when she goes home, now she's going to go home in day 2. So she's having right now lochia rubra, because usually lochia rubra is from the day of delivery to about the 2nd, and some books say 3rd. Okay, so then she goes home, and maybe in a week's time, now, yeah, she went to serosa, and she said, oh, but that's what the nurse told me was going to happen. But all of a sudden, by say day 12, she wakes up and she's in a pool of blood in her bed. Okay. Well, that's scary. Number one. And number two, she says, oh, I need to call the doctor. I need to go to the hospital because this is what the nurse told me. If it reverts back to bright red bleeding, I need to get to the hospital because it's not supposed to do that. It's supposed to go in succession. Lochia rubra. Then about day 3, it goes to lochia serosa, which is more pinkish. And then by day by day, I say 12, 13, and in those, give or take a day or 2, it goes to lochia alba. Okay, so she knows that's not right, and thank goodness that nurse took the time to go over that. Okay, because a lot of times, especially with discharge teaching, the patient is ready to go home, and so it's very hard. So that's why we always teach. Discharge teaching starts on admission. Now, you probably heard that before, but that's why it starts on admission, because it could be a med-surg patient, a pediatric patient, anything. It has to start right on admission because you only have them there for a couple days. And so there's a lot of things that the patient has to know and what to anticipate when they go home. And they need to know the warning signs so that these things happen, they know what to do. Okay. So she might have to come back to the hospital and might have to get what we call the curettage, where they're going to go up and clean out that uterus. Okay. And a lot of times I'll say, do not have anything to drink. Why? Because I'm anticipating that when she gets to the hospital, that they want to do surgery. Okay. Because if placenta fragments, you can't go up inside the uterus now without anesthesia. No. So you're going to put the patient to sleep, and anesthesia will want them to be without having anything to drink. Always thinking ahead. That's why you have to critically think ahead, so that you can make the right clinical judgment. Okay. All right. So now we got subinvolution of the uterus. Again, subinvolution, the definition is slower than expected of a failure of the uterus to return to its normal non-pregnant condition. All right. Now, I already told you, and write this down, this is about the 3rd time I'm saying it, is the uterus descends at a rate of 1 centimeter per day. Okay. All right, and signs and symptoms of a subinvolution would be number 1. Well, what do you think? Well, the fundus wouldn't be going down. It would be going what? It'd be going up. Okay, and we don't want that. It goes down every day. 1 centimeter per down. Okay. Then you would have persistent of lochia rubra. Okay. It's not going to go from lochia rubra to lochia serosa because it's not involuting the way it should. And then you have pelvic pain, and sure, she's going to feel heavy. Yeah, she's what? The fundus going up, the uterus is increasing, she's got more blood, she's going to feel now heavy. Okay, because she's got blood in there. And then she's going to get fatigued because she's bleeding. She's bleeding internally. Never a good sign. Okay. So we're going to teach her when she goes home, you get a temperature. You monitor your temperature. 100.4 or greater, you're going back to the hospital. If you got pain, you're going back to the hospital. If you got persistent lochia rubra, you're going back to the hospital. Foul smelling vaginal discharge. Right. Remember, I always tell you, anything that has a foul smell to it indicates that it's infected. All right. So she's scared. Well, what are you going to do? Okay, nurses, what are you going to do? Well, we're going to reassure her always. You're going to always give comfort measures, and then NPO, like I told you, prepare for surgical intervention, and explain things to her. Just don't go in there and do it. You always explain to your patient. Education is good. Knowledge is good. Okay. So another problem they have after delivery could be a thromboembolic disorder. All right. So what is that? It's a blood clot. All right. So they can throw clots. So you can have your causes of that could be a venous stasis during pregnancy. Pressure behind the knees. Yeah, remember I talked about the stirrups and lithotomy position? We used to have patients in the lithotomy position for hours, and that could be from the pushing stage, that was stage 2, and then when she finally delivers, and then we have her up in stirrups still after delivery. So that caused a lot of these blood clots. And so what happens too is that fibrinogen levels, what happens? It increases during pregnancy, like everything else. But clot dissolving factors in the blood are normally decreased during pregnancy. So you have this setup. You have fibrinogen, which is increasing, and then you have a decrease in clot dissolving factors. All right. And then another problem could be varicose veins. So these are all kind of things you have to be on alert to. And remember the Holman sign. Your patient is postpartum. She calls you and you go to her room and she says, nurse, I'm having a lot of pain in my calf. And you look at the calf and it's somewhat swollen, maybe discolored a little bit. And you go, okay. So what are you going to do? Call the doctor. It's an emergency. So I'm going to call the doctor, let him know what I see. I'm going to receive an order for a venous Doppler. That's the only way I'm going to know if there's a presence of a clot. Okay. Now, hopefully it's not, but if she does, it has a positive Holman sign, then intervention needs to be done. So those are what we call a DVT, a deep vein thrombosis. Another one is an SVT, which is superficial vein thrombosis, SVT. And then you can have a pulmonary embolism, which is never good. And so that's called a PE. All right. So are you watching? You're watching and taking care of this patient? You better believe it. And it's a pretty heavy load on the mother-baby unit because you have couplets. So if you have say you have 4 patients, okay? How many patients do you truly have? You have 8 because you have the baby. All right. Now, nursing care. All right, so let's go over. So I'm going to watch for my signs and symptoms of a PE, pulmonary embolism. Well, she's going to have difficulty breathing. She's not getting what? The exchange of oxygen, right? Okay. And then she's coughing and it's a terrible cough. And then she's complaining of chest pain. Well, you better be running to her room to take care of this problem. All right. So how are you going to avoid all that? I don't want patients like that. Do you? No. So I'm going to teach her not to cross her legs because it does impede blood volume. So if you're crossing your legs right now, I want you to uncross them. All right. And avoid pressure in the popliteal space behind the knee. So say you've been sitting at your desk for a long time. You have to get up and move that blood behind the what? Behind the knee. All right. And then you have early ambulation and range of motion exercises. So if the anti-embolotic stockings are prescribed, then the nurse should teach the woman the correct method of putting on the stockings. So in your lab, that would be good to do is to get the embolotic stockings and to do it on each other. That's fun. Okay. Now, we're going to give her some anticoagulant therapy. So you want to teach her some pretty important aspects of taking this kind of anticoagulant. Okay, so if she has this, you have to use a soft, toothbrush. Okay, you can't use a hard one. It's soft because why? She's going to bleed. Okay. Because this kind of medication is an anticoagulant. That means that it's not allowing the body to coagulate. Okay. So sometimes they have prolonged bleeding even from the minor surgery. So if she's on this kind of medication, she has to what? Tell the dentist, she's got to tell her doctor, her surgeon that she's on this. Because what we'll do is we'll take them off a few days before they're going to have surgery. And then they also could have nosebleeds. So we want to make sure that she's going to cope with this form of medical therapy. Just understand why she's doing it. Okay, so we're going to head into infection or postpartum sepsis, okay, or puerperal sepsis, however you want to say it. So let me tell you, it's an infection or septicemia after childbirth, and it has a fever of 100.4 after the first 24 hours and for at least 2 days during the first 10 days of postpartum. Okay, so again, it's a fever of 100.4, write that down, after the first 24 hours and for at least 2 days during the first 10 days postpartum. Now, the risk. Now, this is why we don't want cracks in the nipples of mommy, because cracks in the nipples of the breast can lead to a postpartum sepsis. Surgical incision, when she had a C-section or she has an episiotomy or she had a tear, anytime you have a break in the skin, they're opened up to what? An infection. Tissue trauma during labor. That's why we limit how many times we do sterile vag exams. We limit how much the perineum. We want to make sure that perineum stretches and doesn't tear during the delivery of the baby. Even the open wound at the placenta site, that is another open area in the body, and it can cause a terrible infection. And then we talked about retained placenta or blood clots. And then endometritis, which is the inflammation of the lining of the uterus, yes, can cause her to be very sick and cause her to have a postpartum infection. So what's the dangers of these? Well, anytime that you have an infection in the body, it can travel. So it can travel, you got the uterus involved, the fallopian tubes, the peritoneum, you can get peritonitis. All that, it can be very life-threatening conditions. So if she presents with an infection, we're going to find out exactly where that infection is, get her to the hospital, get IVs going, get antibiotics, do the cultures. Always do a culture before you give an antibiotic if you're going to do cultures. And because the antibiotics would then skew your results of your culture. Okay. So what's our objective? Think about it. Well, it would be to prevent the infection from occurring. Okay, you got your nurse's cap on. We're thinking like nurses. Okay, that's why when I take care of this patient, I'm going to make sure that everything is done right, because I don't want a postpartum infection. I don't want this lady to get sick. Okay, so what am I going to do? I'm going to teach her hygiene, right? Yeah, remember we talked about every time she goes to the bathroom, we're going to use what? A peri bottle, squirt bottle, warm water. You urinate, you're going to clean first with what? With the peri bottle. Then you take a little tissue and you pat dry. That's it. She's got cyst baths too. She has an episiotomy. She's got cyst bath to keep it nice and clean. Yeah. So these are important. Hygiene. How to pat dry, right? Okay. And after a bowel movement, the same thing. All right. I want to make sure she gets adequate rest and nutrition. All right. Because she's healing. Either she's healing from an episiotomy, or she got a C-section, or just labor, folks. She needs to rest, and she needs to have proper nutrition for healing. All wounds like protein. Okay. So we got to make sure she eats right. And then teach and observe for signs of infection. Absolutely. And she's going to go home. So you want to make sure that she knows the signs of infection. And then teach her how to correctly apply perineal pads from front to back. All right. And teach her to take all her medication, all the all the antibiotics they give her, whatever they gave her as prescribed, make sure that she knows how to take them. First of all, why she's having to take them, and how to take them, and the importance that she does take them, especially the antibiotics, until they're finished. Okay. Now, another infection is called mastitis. Oh, mastitis. Mastitis, like I said before, is an infection of the breast. And what happens is you get, these are your signs and symptoms. You get redness and heat in the breast. Not nice. Tenderness is extremely tender. Edema and heaviness of the breast. Absolutely. You know, she'll have a fever, 100.4 or greater. She's very uncomfortable. And on page 255, there's an example, figure 10.2, and that is a typical mastitis. And you can see how red it is. And this is several weeks after birth in the woman who's breastfeeding. And the bacteria usually enters the breast through the small cracks in the nipples. Remember? I told you that. So I got to make sure that every time that she breastfeeds, well, if she complains to me about this, what am I going to do? I got to assess it. So I have to go and watch her and see how she applies that baby to the breast. And another thing is how she takes the baby off the breast. Okay. And then you have, if she has engorgement or milk stasis, it increases the risk for mastitis if she's not emptying it. And if she's not breastfeeding, okay, then we have to handle that engorgement. So like cold packs and decrease, wearing a tight bra for several weeks will help decrease engorgement. Okay, so do I want to avoid this? You better believe I do. Okay, so fever, chills, and other systemic signs of infection. Oh yeah, it's on, and it's all there for you. Purulent drainage. Oh, purulent drainage. It may or may not be presented, but again, the woman usually has fever, chills, and other signs. And if not treated, the infected area becomes encapsulated. What happens when I say encapsulated? It comes like it has its own little wall around it, and then from that that's how an abscess is formed. Okay, and then that is very painful. Okay. Now, the infection is usually outside the ducts of the breast, and the milk is not contaminated. But if they're giving her antibiotics, then you have to continue the removal of milk from the breast as the primary treatment for mastitis. Okay, so what you can do is you can pump and dump. All right, but you got purulent drainage. You don't want the baby having that, and then she'd probably have a mild, analgesic, usually about sometimes Percocet, Vicodin, or hydrocodone, and then if it really gets bad, sometimes they have to do like a little incision, IND. It's called IND, and so it's incision and drainage. Yeah. Now I tell you, this happens, and they walk in. I had one patient that walked in, and she had her arms up in the air like this. She had an arm, but she had like on the right breast, and underneath, your arm, you have a tail fence, and that was also swollen. It really got bad, and so she came in and she couldn't move, and she was measuring. And these are reasons why women don't want to breastfeed. Is because they probably hear from their friends about it. Okay. So again, you got your treatment. I already went over that with you. So it's right there in the book. They can, if you can continue to breastfeed from the unaffected breast. Okay. We always want them to encourage fluid intake and wear a supportive bra. And she needs a lot of support. Oh yeah, a lot of support. Okay. And they probably give her antibiotics and a mild painkiller. Okay. But sometimes I could give her more than a mild painkiller. I'm gonna be honest with you. I've had some women that were just a measure it. All right. All righty. Let's go on. Let's go talk about some mood disorders. Postpartum depression. All righty. Well, you heard about I think you've heard about baby blues. You've heard about, and let me tell you, baby blues is another name for it now, and it's also known as an adjustment reaction. Okay, this is when mom is kind of like down, sad. Why is she like that? Think about it. I remember when I had my first baby. Oh my goodness, it was so overwhelming going home and the responsibility of a baby. I was young, and you don't eat right. Okay, you don't sleep. Oh no, you don't sleep, and you're overwhelmed, right? Is that all about baby blues? Sure, yeah, yeah. You even look at your body and you go, okay, this is not the body I used to have. All right, does that cause you to be a little blue? Yeah, it's all according to how women or the woman perceives things. Okay, so some people are able to handle things a little easier than others, and some just get really down. That's baby blues. All right, and the reason why they probably call it an adjustment reaction is because going home after having a baby is a big adjustment. No matter how well you think you are prepared, are you ever really prepared? No, no, because all of a sudden now you have the responsibility of another human, and that could be very overwhelming. Okay. Okay. And then you have postpartum mood disorders, and you can get into more of a postpartum depression. Okay. And what happens during a postpartum depression is that you lose the enjoyment in life. So you're going, it's a little deeper. Now you're going a little deeper. Maybe, you didn't get any support at home, and all those things that I just described to you, they kind of get like worse. Okay, they increase. So no more do you enjoy life. You have disinterest in others that you normally like to do in relationships. You don't have an interest anymore. Um, you feel, well, remember I told you you didn't feel good in the beginning with baby blues? Well, now you have an increase in this. I'm feeling quite inadequate. I really don't know what I'm doing. Oh my gosh. It gets deeper. Okay. Sometimes you have an inability to cope. Sometimes this is where you're getting up in the middle of the night and you're trying to breastfeed because you know that's the best thing for your baby, and the baby's not latching on, and all the baby's doing is crying. You just don't have the ability to cope because you're tired. So this gets really difficult for a woman, especially if she's going home and she has no support. If maybe she's a single person, no support. Then you have a loss of mental concentration and inability to make decisions. Yeah, I mean, you're overwhelmed with everything, and it's really now much deeper. And so you just can't make those critical decisions. So that would not be a good time to, make big decisions. And then, of course, your sleep, and you have a loss of appetite, so you're not getting the nutrients you need. Maybe you're low on iron, so you're having iron supplement. So now you're constipated. It just gets, one thing cascades over another thing. Okay, so that's depression. All right, and she needs to get help with depression because it can affect the entire family. So she needs to get some help, and we want them to always remain in touch with reality. And so whoever's in the home should help her, support her, and a husband can get up during the middle of the night and get that crying baby and change his diaper and bring the baby over to mom to breastfeed, and then after mom gets done, let mom go back to sleep and take the baby back to the crib. Now, these are things that husbands and wives need to go over prior, during the pregnancy, so they have a plan. And sometimes what we do as nurses, we help them in the perinatal time. We help them come up with a plan for afterwards because we know that these things can happen. Okay, and then you go even deeper and you get postpartum psychosis. Well, postpartum psychosis, they really do have an impaired sense of what's reality. Is psychosis is much less common. Thank goodness. A woman may have a psychiatric disorder, but they might have bipolar to begin with, and they got pregnant. And then they have major depression. And remember, that's all important to know on that first initial OB visit, if there is any history of postpartum disorders. I mean, not postpartum disorders, any kind of mental disorders in the very beginning, because they're not going to get better during pregnancy. And then after she delivers, she may have a really tough time. And we've had patients where they would hear voices, and the voices would tell them that they should kill their baby, that they're not worthy to have this baby, and on it goes. It's very, and it's very deep and very dark. And so you don't want your patient to get there. So, okay. So that's the end of your chapter. On page 257, you do have a little bit about the homeless mother and newborn. And this does happen where, homeless, they don't have a permanent home. And so we want to recognize that before they even leave. And then we would get a social worker in there to intervene and to help support them and get some supportive services. Yeah, because we don't want them to go back out in the streets with their newborn. Okay. All right. So again, you have your unfolding case study at the end. So here you have it. And this was a really nice, I hope that you have been doing the unfolding case study, as I tell you every week. And then really look at those questions. So let's look at that right now. I'll read them with you. So what factors during delivery may contribute to postpartum hemorrhage? All right, so it does give you a little scenario and tells you. And so if you can't answer that, then you need to go back into the chapter and read about postpartum hemorrhage. And then number 2, what assessments would the nurse make to determine if her logia is excessive? Remember, she got more than 500 mLs after vaginal delivery, she has a hemorrhage. If she's bleeding more than 1,000 mLs after C-section, she's got a hemorrhage. And what are you going to do? Write down the steps on how to take care of a patient after a hemorrhage. Okay. That's number 1. Number 2, I want you to do this. Write down the signs and symptoms that your patient would exhibit during a hemorrhage. You will see these questions again. All right, and number 3, because Tess has not ambulated to the bathroom, what safety precautions need to be initiated for her? Yeah, that first time you get your patient up after delivery to go to the bathroom, she can get very lightheaded and dizzy, and she could go down on you. So I always got my patient up. I worked postpartum, and I let my fellow nurse know that, yes, I'm getting my patient up for the first time, number 1. Okay. Number 2, because everybody's busy, but I did let her know in case I needed help. Number 2 is I always had a chair behind my patient. Okay, these are little tips, I walked her to the bathroom. She never went to the bathroom alone. No, she always had a nurse helping her. I had her pad on, her chucks between her leg and the fluid chucks. Okay, and we walked to the bathroom. Now we may waddle, but that's okay. And I had that little chair behind me. It's just a it's a little chair we have in the room, and just in case. Why? Because if she goes down and gets lightheaded, she tells me, "Oh, nurse, I'm feeling really lightheaded. What am I going to do?" Sit her down. Let her take some good deep breaths. Let the body come into more homeostasis, and then get it back up again. And then get her to the toilet. Then as we're over the toilets, you're gonna bleed an awful lot. So you want to make sure you have gloves on and you have I always had like a yellow gown, and make sure that when I took the pad off, I mean, she's on the toilet. Okay. I'm right there with her, standing in front of her. Okay. And they go to the bathroom, and then we go over pericare, and I show her what to do. And then I put a new pad on. She stands up. I put a new pad on. Okay. And then I get her waddling back to bed. And I still have the chair behind me because why? Because I just drag it because in case she goes down again, she's not going to hit the floor. When your patient hits the floor, you got to get risk management involved, and you got to get her. It's not good. Okay, you have to get a skull X-ray and all that kind of stuff. So, do I want my patient hit the floor? No, but I know because I got my thinking cap on, and I know I can anticipate that I could have someone to get lightheaded and dizziness. Okay, so that is getting your patient up to go to the bathroom after delivery. Okay, remember your patient should never walk to the bathroom by herself. All right. And then the next one, what safety precautions need to be initiated for her baby? All right. Well, before they left the labor room, we had the baby identified with the bracelets and the safety band. Okay. Make sure the baby's always in the crib, right? And the baby's at bedside, and make sure that you got the bowl syringe in the crib. Okay. So the baby gets kind of, if it has a lot of fluid, they need to be bulb suction very, very quickly. Okay, so go over that. You can't answer that? Go back into the chapter. And then what teaching would the nurse offer? All right, I'll let you answer that by going back into the book. Make sure that you read the chapter. We just went through the chapter, and the PowerPoints are on Canvas under announcements. There is a great video on postpartum hemorrhage. There's a video on postpartum lacerations and immunization postpartum. So take the time. They're not long videos, but they are informative, and make your notes from them. Okay. And then I will be doing chapter, I think, let's see, the next chapter that we didn't discuss. Let me go back to our syllabus, which is my blueprint, right? And it'll be chapter 12, the term newborn. So you can do that reading, and then I'll be talking about that, and I'll send you another video. Okay, happy reading. Read the chapter. Bye-bye, everybody.